Imagine you are sitting in a doctor's office. The year is 1950. The walls are white. The smell of antiseptic hangs in the air like a warning. The doctor across from you takes a long breath, sets down your file, and tells you that you have cancer.
I have the results here.
And then he reaches for a scalpel. That was, for most of history, the only real answer medicine had. Not pills.
The tests have come back. I'm afraid
Not
the
radiation
diagnosis is not
protocols
good.
mapped to millimeter precision on glowing screens. Just a blade, a prayer, and a decision about how much of you could be removed before you became something unrecognizable. Cancer is not a modern disease. It has existed in human bodies since before recorded history, found in Egyptian mummies, described in ancient papyri, named by a Greek physician who looked at a tumor spreading its jagged edges across flesh and thought it looked like a crab. Carcinos. The crab. That name has survived every century since, and the disease has survived with it. But what doctors did about it, what patients believed about it, what it felt like to receive that diagnosis before the age of modern oncology, that is a story almost entirely lost from public memory. This video is about that story. We are going back to a specific moment in time, to the years just before chemotherapy existed, just before the word oncology became a specialty, just before the world understood what cancer actually was at a cellular level. We are going to walk the hallways of mid-century hospitals, sit inside the surgeries, smell the ether, feel the fear. We are going to meet the patients who survived, and understand why most of them didn't. And at the end of all of it, we are going to ask a question that still doesn't have a clean answer. What, exactly, did doctors get right? What did they get terribly wrong? And what did the human body manage to do entirely on its own? But this story doesn't begin in 1950. To understand what was happening in those hospital rooms, you have to go back further. You have to understand what people believed cancer was, because belief, in medicine, shapes everything. For centuries, the dominant theory was rooted in something called humoral medicine. The body ran on four fluids: blood, phlegm, yellow bile, black bile. Disease was an imbalance. Cancer, specifically, was believed to be caused by an excess of black bile, melancholy in its most literal, physical form. Tumors were not foreign invasions. They were the body turning against itself through imbalance, through excess, through something fundamentally wrong with the patient's nature. This wasn't a fringe belief. This was Hippocrates. This was Galen. This was the medical consensus that held for nearly 2,000 years. What it meant in practice was devastating. If cancer came from inside you, from something wrong in your fundamental constitution, then cutting it out was almost meaningless. The imbalance remained. The dark bile would return. The tumor would come back. And in many cases, it did. Not because the theory was right, but because surgery in the ancient and medieval world was primitive enough that removing a tumor completely was nearly impossible. So patients would watch their tumors regrow, and physicians would nod, and the theory would be confirmed again. This created a medical culture, lasting well into the 18th century, in which not treating cancer was sometimes considered the more merciful path. Hippocrates himself reportedly advised against treating certain advanced tumors. The interference, he believed, would only accelerate the patient's suffering and death. What they didn't understand was that this wasn't wisdom. It was the blind spot of a theory that had no mechanism for being wrong. And then something changed. In the 1840s, a surgeon named John Collins Warren performed what may have been the first operation conducted under general anesthesia. The patient was breathing ether. The room was quiet in a way surgical rooms had never been before. The screaming had stopped. This was not a small thing. Before anesthesia, surgery on a conscious patient had to be fast, catastrophically, brutally fast. Speed was mercy. A tumor embedded deep in a breast or a jaw or an abdomen required precision that screaming, thrashing, suffering patients simply could not permit. Surgeons worked in seconds. They worked in a narrow window between the patient's endurance and death from shock. Anesthesia changed the clock. Suddenly, surgeons
You're
had
ready,
time.
miss. Yes, I am.
They could be careful.
We'll start with this.
They could try to get clean margins. They could attempt what had previously been unthinkable. And they did. The second half of the 19th century became an era of radical surgical ambition unlike anything medicine had seen before.
Take her to recovery.
Surgeons began removing
All
entire
right.
breasts, entire lobes of lungs, entire sections of jaw and skull. They operated on cancers that would have been declared untouchable a generation earlier. A Viennese surgeon named Theodor Billroth
Initiate
removed
anesthesia.
sections of stomach. A New York surgeon named William Halsted developed what he
Lamp is in
called the
position.
radical mastectomy, an operation that
Anesthesia
removed
ready.
not just the
Begin
tumor,
countdown.
not just the breast, but the
Adjusting
underlying
flow.
chest muscles,
I don't wanna
the
do
lymph
this.
nodes,
Just
everything
relax,
that the
breathe
tumor might
deeply.
conceivably have touched.
Here we go.
No.
Halsted believed
Count with
cancer
me.
spread
1,
outward in concentric
2.
rings, like ripples in water. If you removed enough tissue, an ever wider circle around the center, you could theoretically catch it all.
Can you
His
hear me?
operation was
Are you
mutilating.
awake? Blink if
Women
you can
who
hear
survived
me.
it lost the
What is
shape
your
of their
name?
chest, the use
Can you
of their
squeeze my
arm,
hand?
the landscape of their own body.
You're doing very well.
But Halsted had
Just
data.
a quick check.
His patients were living longer than anyone else's.
Okay.
The operation worked, at least for a while, for some cancers caught early enough. For decades, his approach defined Western oncology. The answer was always the same: cut more. But this was only part of the story. By the early 20th century, a second weapon had emerged, and it came from an accident. In 1895, Wilhelm Röntgen discovered the X-ray. Within years, physicians began noticing something strange: tissues exposed to radiation were changing. Cells were dying. And in some cases, in some remarkable, early, poorly understood cases, tumors were shrinking. Radiation therapy was born not from theory but from observation. Nobody in the first decades of the 20th century fully understood why radiation worked. They knew it did something to cells, something destructive, something
hold of
that
the
seemed to
rail.
affect rapidly
got
dividing
you.
cells more than
Slowly
slow
now.
ones. The mechanism was
standing.
opaque.
You're doing great.
The dosing was guesswork. The machines were crude and the side effects were catastrophic. Early radiologists, the people who operated the machines, who calibrated the doses, who stood beside patients day after day, had no idea they were being slowly killed. Their hands blistered and scarred. Their blood counts dropped. Some of them developed leukemia decades later and never connected it to the years they had spent beside those humming, glowing machines. And yet, for patients with certain tumors, particularly tumors of the cervix, the throat, the skin, radiation offered something surgery could not: a way to destroy a cancer without cutting it out. A way to reach places the scalpel couldn't follow. By 1950, radiation therapy was the second pillar of cancer treatment. It was painful, imprecise, and deeply damaging to surrounding tissue, but it was real. It worked. And in the hospitals of mid-century America and Europe, oncologists, still a nascent specialty, still fighting for legitimacy within medicine's hierarchy, were using surgery and radiation in combination, developing staging systems, keeping records, arguing fiercely about outcomes. What they didn't have was anything that could follow cancer into the blood. Anything that could reach a metastasis in the liver, in the bone, in the brain. Anything systemic. Here is what a cancer diagnosis in 1950 actually looked like from the inside. You probably found the tumor yourself. A lump in your breast, a sore that wouldn't heal, blood where there shouldn't be blood. You waited, because people waited. Because seeing a doctor was expensive and frightening and the information might be worse than the uncertainty. By the time you made the appointment, by the time you sat across from that man in the white coat, the tumor had often been growing for months. He examined you. He may have taken a biopsy, a small piece of tissue, examined under a microscope, or he may simply have looked at the mass, palpated it, and decided. The pathology of 1950 was not the pathology of today. Diagnoses were sometimes wrong. The staging of cancer was still being standardized. Different hospitals used different systems, different terminology, different criteria. If you were told you had breast cancer, and if it had not spread beyond the breast, you would be referred for surgery. If you were lucky, you survived the anesthesia, survived the blood loss, survived the infection that lurked in every hospital wound of the era. If you were very lucky, the margins were clean. If you were unlucky in ways nobody would confirm to you directly, the cancer had already seated itself somewhere else, somewhere invisible, somewhere waiting. The follow-up was minimal by modern standards. There were no PET scans. No MRI. Blood tests existed but were blunt instruments. If your cancer came back, you often found out the same way you found it the first time: you felt something, you waited, you went back. The 5-year survival rate for breast cancer in 1950 was somewhere around 50%. For lung cancer, which was rising sharply because of cigarettes, it was close to 5%. For leukemia in children, it was near zero. These numbers were not publicly shared in the way we share them today. Physicians often didn't tell patients their diagnosis at all, not because they were callous, but because the medical culture of the era held that hope was a form of medicine, and that certainty of death served no one. Patients were managed. Protected from their own prognosis. Told they had a growth, a lesion, a shadow. Told the doctors were handling it. And yet, here is where the story becomes genuinely strange: people survived. Not most of them, not the ones with advanced disease or the wrong tumor type or the wrong decade to be sick in. But some of them survived in ways that medicine of the era could not entirely explain, and that science still struggles to fully account for today. There is a phenomenon, documented across the entire history of cancer medicine, called spontaneous remission. Tumors disappear. Not from treatment, from nothing that medicine did. The patient goes in for surgery and the tumor is no longer there. The metastasis vanishes on follow-up imaging. The cancer that was supposed to kill someone in 6 months is gone in 3. This is not a myth. It is documented. It is rare, estimated to occur in somewhere between 1 in 60,000 and 1 in 100,000 cancer cases. But it is real, and it has been real for as long as medicine has been recording its observations. In 1950, before chemotherapy, before immunotherapy, before anyone understood that the immune system could attack cancer cells, these cases were filed under the general heading of the inexplicable.
The world outside.
Some physicians attributed them to God.
Morning paper.
Some attributed them to fever.
Looks like a
There
nice
have been
day for
observations
laundry.
going back to the 19th century suggesting that patients who survived serious infections sometimes saw their tumors shrink, a phenomenon that a New York physician named William Coley would spend his career attempting to exploit deliberately. Coley's approach was controversial in his lifetime and would be discredited after his death, only to be partially rehabilitated a century later when immunology matured enough to explain what he had been observing. He was injecting cancer patients with bacterial toxins, deliberately giving them infections, and watching, in some cases, their tumors respond. He was, without knowing it, stimulating the immune system to do something that is now the entire basis of a treatment category called immunotherapy. But in 1950, nobody believed this. The immune system and cancer were not understood to be connected in any meaningful way. What modern science reveals, that the body maintains a constant surveillance of its own cells, that immune cells patrol for the markers of abnormal division, that cancer in many cases succeeds not because the immune system is absent but because the tumor has learned to hide from it, was decades away from being articulated.
I'm wearing my
What
own
patients and
clothes.
physicians of 1950 didn't know, and couldn't know, was that some of the survivals they were attributing to surgery, or to radiation, or to prayer, or to sheer constitution, were actually the immune system recognizing the cancer and destroying it. The treatment had simply bought enough time, reduced enough burden, created enough opening, for the body to finish the job itself. There were other strategies in this era that live in a more complicated historical space. Dietary interventions were common. Max Gerson, a German-American physician, was promoting a treatment regimen built around raw juices, coffee enemas, and the elimination of salt and fat. He claimed cures for tuberculosis and cancer both, and he had supporters, some of them prominent. His evidence was anecdotal, his methods were unconventional to the point of bizarre, and mainstream medicine rejected him forcefully. But there were patients who survived on his protocol who were expected to die. Whether they survived because of it, or despite it, or because their cancer was never as lethal as the initial diagnosis suggested, or because something else entirely intervened, is genuinely impossible to determine from the records that exist. What we know now is that diet and cancer are related, not in the simple, direct way that Gerson believed, not as a direct cure, but as a factor in immune function, inflammation, cellular repair. The gut microbiome, the relationship between processed food and cancer risk, the role of specific nutrients in DNA repair mechanisms, these are active, serious research areas today. Gerson was wrong about almost every mechanism he proposed. But the intuition that what you put in your body mattered, that was not entirely wrong. There were also the psychological interventions of a particular kind. Not modern cognitive behavioral therapy, not structured support groups with clinical oversight, but the informal, persistent, culturally sanctioned belief that attitude mattered. That fighting mattered. That people who refused to give up sometimes didn't die when they were supposed to. Medicine today is cautious about this territory, because the evidence is genuinely ambiguous and because the idea that attitude causes survival can slide easily into the implication that patients who died did so because they didn't fight hard enough. That is a cruelty we should not import from the past. But the relationship between psychological state, stress hormones, immune function, and cancer outcomes is real. It is not dominant. It does not override the biology of tumor stage and type. But it is there, documented in the literature, a thread in the weaving. What people in 1950 believed intuitively, that the will to live mattered, was not entirely wrong. They were just wrong about the mechanism, and they used that belief in ways that were sometimes compassionate and sometimes devastating. And then something changed again. Not in 1950. Just after it.
The coffee is nice,
in
but I keep seeing the
1947,
hospital
a
walls
physician
in the
named
steam.
Sidney Farber had
Maybe
given a
that's
group
okay.
of children with
I just need
leukemia
to
a
remember
substance
what's
called
outside now.
aminopterin, a drug that blocked the production of folic acid, a nutrient that rapidly dividing cells needed to replicate. The children went into remission. Temporary remission, brief remission, remission that didn't last, but remission. Something in a pill had done something to a cancer that surgery couldn't reach. The era of chemotherapy had technically begun, though nobody in 1950 was quite ready to call it that, and the drugs themselves were still years from anything resembling effectiveness or tolerability. By 1956, methotrexate would cure a form of cancer called choriocarcinoma, completely cure it, in women who had been dying, with a drug. The proof of concept existed. The question was no longer whether drugs could fight cancer. The question was how to make them better. What followed, the decades of cytotoxic agents, the hair loss and nausea and devastated immune systems, the brutal effectiveness of drugs that killed cancer cells and normal cells with equal enthusiasm, is another story. It is the story of how medicine traded one kind of damage for another in the attempt to buy survival. It saved millions of lives and destroyed the quality of others. But that story begins just after the frame of this one. In 1950, in those white rooms, in those moments of cold diagnosis, what doctors actually did was this: they cut, and they burned, and they watched, and they waited. They offered hope without evidence, silence instead of prognosis, certainty where none existed. They were doing the best they could with what they had, which was almost nothing, and some of the time it worked, which was almost impossible, and people survived, which medicine took credit for and the body deserved. What we still do wrong today is believe that survival always has an explanation. That outcomes follow rules we have fully understood. That the body is a machine we have finished mapping. What we forgot, in building the extraordinary apparatus of modern oncology, is what those physicians in 1950 had to accept by necessity, that the body contains processes we cannot see. That the immune system is not passive. That the will to understand a disease is not the same as having understood it. The crab is still with us. It has been with us for as long as we have been human. What changes is not the nature of the disease but the quality of our attention to it, the precision of our questions, the honesty of our answers, the willingness to look at what survives when everything we expected to save someone has failed. Some things were lost in the distance between 1950 and now. The intimacy of not knowing. The humility of a medicine that could not promise what it could not deliver. The simple honesty of a physician who looked at you and said, "I don't know. But we will try." And in that trying, something happened. Some cells stopped dividing. Some tumors retreated. Some people walked out of those white rooms into the rest of their lives. What remains is the question they couldn't answer then and we still can't answer now: was it the medicine, or was it always you?